for this opportunity.
So Kate, let me do the disclaimers first. I'm Brad Power, co-founder and president of the Cancer Patient Lab. And this is our weekly webinar series where we talk either to patients about their cases or to innovative companies, experts at the cutting edge, and then the patients kind of do a question and answer to learn about whatever that area is. Today, we're honored to have Katerina Postovalova as a scientist who's working at BostonGene. But first, the disclaimers. There are two. One is this is not medical advice. This is just information that you can take to your medical team. It's to arm patients and caregivers with information they can use in conversations with their medical team. And the second is that everything that we say today will be made public. So if you're concerned about saying anything or being quoted or having your image presented, go hide now, because all the images will be presented, and as well as all of the content. We will do I always think of this as the live studio audience. We're like Saturday Night Live, and this is the live studio audience, but we're going to have a recording and a summary of meeting notes and a detailed transcript and slides. So this will all be available for posterity and anyone who follows. With that, let me introduce Katerina. So we connected initially with BostonGene through Sumit Subudhi. Sumit Subudhi is one of our very honored and esteemed gurus that we really listen to closely. He's an expert in immunotherapies in prostate cancer. And he described how at MD Anderson, he and others are working with BostonGene to guide their treatment decisions with patients. And so we said, well, we need to make BostonGene then available. Rick Stanton is here. I want to credit Rick Stanton with educating all of us about immunotherapies as a possible best path of treatment options, because it's fighting the disease, a cancer system, with an immune system. And so we've always been very intrigued. All of the things being equal, you can have targeted therapies, chemotherapy, radiation, you can have all kinds of therapies. But if immunotherapy works, then you have a much greater chance at a durable response. And so anything that would help guide us towards immunotherapies is valuable. Rick was early pointing us to a couple of companies, Akoya and NanoString, that are hardware manufacturers that provide some of the tools that allow spatial analysis. They can help look at the tumor microenvironment and figure out whether an immunotherapy is a likely response. And so we talked to them, but they don't talk directly to patients. They only talk through labs. And it seemed that BostonGene was at the cutting edge of using that technology to help guide patients, particularly with their tumor profile and their immunotherapy, like whether immunotherapy would be a likely therapy option for them. So we've been very interested in this. In our initial conversations with Michael Hensley, who's here, about BostonGene, when Sumit Subudhi put us in contact with BostonGene, Rick was very interested in getting under the covers, behind the curtain, to see the wizard. Who's behind the curtain, what's going on inside that lab, and what are you doing, so that we can understand even in more detail what happens inside a lab that's doing the kinds of analysis that help us patients guide our path forward. So that's all the background. So we've already had a session with Michael and with some of his colleagues to get introduced to BostonGene. And this session is with Katerina to go deeper into the technology and pipelines and processes of the lab that enable BostonGene's reports. And we also, I should say also, we have a number of patients who have taken advantage of the BostonGene services, including Brian, who's on here, and then Bob Germankin. And so they'll have some questions that come from that perspective, and I encourage them to be selfish and ask the questions that concern them. With that, I'll turn it over to Katerina for 10 or 15 minutes of slides and introduction, and then we'll have most of the time, 45 or 50 minutes devoted to question and answer. Thank you.
Thank you so much. Thank you. One sec, I will start sharing the screen.
Working.
Yes, all good. So thank you. Thank you so much. My name is Katerina Postovalova. I'm with BostonGene about 4 years, and I started as an analyst and analyzing the MxIF data, and I'm happy to present those results and product to you. So multiplex immunofluorescence data. We can work with non-malignant tissue, we can work with malignant tissue, we can work with solid malignancies, we can work with hematological malignancies if the locus of tumor is located in the lymph node or in bone marrow samples. Here's just an example of images we can receive and analyze. We offer multiplex immunofluorescence in addition or instead of standard IHC. So you all know that for standard IHC, usually we utilize one marker per one slide. And for multiplex immunofluorescence, we can stain up to 40 markers, and this can be increased in the near future and analyze much more biomarkers on the single slide. And also multiplex immunofluorescence give us some capabilities to study not only the presence or absence of different markers and calculate the scores, but also identify the different subtypes of immune cells, identify the localization of those immune cells, and some complex metrics like contacts between different cells, distances between different cells, and etc. I will provide more examples later this presentation. So in-house, we utilize the pheноcycler fusion machine. This machine provided by Akoya. BostonGene is a qualified CRO service provider for Akoya. So how this technology works? So first step, we cover the whole tissue with all antibodies, and then we just put free reporters. We name this as reporters, visualize them, remove these free reporters from the tissue, and repeat this cycle until all antibodies will be covered. So if we decided and selected the panel of 40 markers, so we just repeat the cycle until all our markers like CD3, CD4, PD-L1, some epithelial markers will be covered and will be imaged for us for the analysis. As a result of this wet part processing, we receive some raw MxIF images, like on this example, and we see the morphological structure of the tissue. So right now we can see the tumor-enriched area. Here is cyan and gray color on the image. We see some colored dots here in purple, which are different subtypes of immune cells. We also see some colored dots here, red and yellow, which represent different subtypes of immune cells. And on this step, even without any analysis and any comprehensive bioinformatics support, we see the heterogeneity of the tumor tissue. So we see the tumor area, we see some stromal component, we see increased immune infiltration in the stromal component, and we also see that some immune cells are present in this part of the tissue, and some of the immune cells are present on this part of the tissue. And next, what we need to do, we need to investigate what the cell types. For example, if red dots here are CD8 T cells, which is cytotoxic T cells or killers, and those cells can potentially affect the tumor. So we need to investigate how far away those cells from the tumor cells within the malignant tissue sample. For that purpose, we have developed our own artificial intelligence-based approach how to analyze these multiplex immunofluorescence images. So we always start with the raw MxIF images. We can work with the whole tissue section, for example, if it is a resection material. We can work with the core needle biopsies. We can work with the tissue microarrays, for example, if we would like to analyze multiple samples like multi-regional analysis or several different time points. So all of this can be analyzed in stain. And the first step is a AI-based cell segmentation. We have developed our own approach for cell segmentation. And as a result of this step, we receive like a binary mask and with multiple contours. And each contour here represents a specific cell type on the slide. So if you will compare those three images between each other, so this is like a standard H&E image, which all medical doctor pathologists analyzed. And for example, looking at this small region of interest, you can immediately see like malignant component, stromal component, and non-malignant component. We can see the same on multiplex immunofluorescence image, and we can see the same presence of different cells on the cell segmentation after the cell segmentation step. And what we need to do next, we need to assign each cell segment as a specific cell type belongs to, and this step name as a cell typing. And you can see it here. So on the cell segmentation, we just received the information about all of the cells without specification of the cells. And next step, we see all of the cells on the slide. And right now we know the specific cell type of each cell. So for example, the brown color here represents the tumor cells. The gray color here represents the stromal component. Some colored dots represent the different types of immune cells, and yellow color here represent the non-malignant epithelial. And we also include in our pipeline metrics not only based on the cell segments, like count the different cells, calculating the distance between different cells, calculating the direct contact between those cells, but we also take into the account the different approach, like mask-based approach, to analyze the morphological structures which cannot be described in the format of the cell segment, like stromal component, like blood vessels, sometimes like macrophages, because they have like very complex shape. So after the cell segmentation step is completed, we do the cell typing analysis, and using the even 20 or 30 or 40 antibody panels, we can identify that much of different cell subtypes. So here's just an example of MxIF images we can stain and receive after the wet lab processing. And here, And here is an example of cells which we can identify from the single slide. And each dot on this UMAP projection corresponds with the different cell types. And using our standard panels, we can analyze different subtypes of epithelial cells. We can analyze different subtypes of immune cells like CD40 cells, CD80 cells, both of them PD-1 positive, PD-1 negative. So we can really focus on the tumor microenvironment. Why do we need to have this? I learned that you have already heard about our tumor portrait report. In tumor portrait report, we also really focus on the tumor microenvironment, and we utilize several approaches how to study the tumor microenvironment based on the bulk RNA sequencing data. So on one approach, we analyze or predict the percentages of different subtypes of immune cells within the bulk of the tissue. And second, we just analyze which component within the tumor are present or absent using the gene signature-based approach. But both approaches completely lack information about the spatial organization of the tissue. And here on the slide, why it is important. So here I put 3 different examples. And for example, example 1 and example 2 will show us almost the same amount of immune cells based on the bulk RNA sequencing result, when we will see the percentages of immune cells in the tissue. But these cases can be different from the spatial organization point of view. So for example, first case, you can see the gray color here, which represents the malignant compartment. Malignant compartment. And you see the blue and red colored dots here, which represent the different types of immune cells. And we see that almost all immune cells are located on the tumor stromal border, and the tumor itself is a desert. And the opposite picture we see on the second image, where we see a lot of colored blue and red dots, which penetrate the tumor itself. And this will be a real inflamed tumor sample. And we can see those differences on imaging data, on multiplex immunofluorescence data. So this is the main reason why we would like to supplement our tumor portrait report based on the bulk RNA sequencing data with a spatial analysis. Here I put some examples. So we did one study in prostate cancer, and I would like to highlight this, that of course, when we speak about multiplex immunofluorescence, we mostly focus on the tumor microenvironment because we would like to provide the prediction of therapy response to immuno-oncology, but we also can analyze the different metrics and morphological structures and find their associations with, for example, MRI positive or MRI negative patients with a better or worse prognosis. And in this work, we analyze the distribution of the stromal component, we analyze the density of tumor cells itself, and we analyze the presence of immunoinfiltration in different compartments on the tissue. So the color code here is the same. The brown color here represents the tumor-enriched area, malignant cells, and we can see the tumor here. And yellow color here represents the non-malignant component, non-malignant compartment of the tissue. And colored dots, green and purple, represent the different subtypes of immune cells. So green dots here represent the T cells, and purple dots here represent the macrophages. And if we will analyze the tumor microenvironment more deeper, we will see that in tumor area, in tumor cells enriched area, we see less immune infiltration than in non-malignant compartment. So we can expect, for example, the most of immune cells we see on the bulk RNA sequencing probably came from the non-malignant component. Another approach, so I think I just have a couple of slides. So we can analyze, we can calculate the percentages of immune cells. We can calculate the absolute amount of immune cells. We can calculate the distribution of these immune cells. So where those are located in the tumor-enriched zone, in the tumor stromal border, in the tumor in the stromal component near the blood vessels. We also can do some comprehensive analytics. And here's an example of this type of analysis, the analysis of cellular niches or cell-to-cell interaction analysis. So how it works, this is a graph-based analysis. And on the left picture, you can see, this is actually cell segments we saw on the second slide, colored by different cell types. Yellow color here represents epithelial cells, and colored dots here the same represent the different subtypes of immune cells. But on this image, we have the same segments, but annotated in the cellular niches. So right now, for example, when we see on the orange color here, we mean not like epithelial cells, but we mean the, for example, high density of epithelial cells with almost zero presence of immune cells in this type of the community. And for example, the green color here, we mean that this is a stromal component with increased proportion of immune cells within this community. So right now we had more spatial analysis and spatial meaning in the color coding and the analysis itself. We also have prepared the tumor imaging report. So I mentioned that this analysis and this information can be provided as a supplement to our tumor report. So we focus on the malignant cells and on the tumor microenvironment. We, of course, try to simplify the analysis we provide, not to push all of this comprehensive analytics and data visualization. So we just calculate the percentages of cell, trying to compare current patients with the patients with the same diagnosis like we do in our tumor-reported report, and trying to match with a widely used biomarkers in clinical practice. And this is the thought from my presentation. So I can answer to any questions based on these slides, or can stop sharing and we can start talk.
Thank you very much, Kate. If we could use the raise hand feature to have people comment, that way we can sort of manage who speaks. I'm sorry, was that Michael who was speaking?
I was just joking with Rick. See, Rick, I could have never delivered it like the expert Kate. So
this beautiful presentation.
I would like to start with Rick. Go ahead, Rick. Katerina, could you stop screen sharing so that we can? Yeah, there we go. Go ahead, Rick.
Beautiful presentation. Love it. I think emphasizing why and why do we care is probably coming up. Phil just responded to Pluvicto, and that's awesome. We were commenting on not many people in our little lab responded to Pluvicto. So would your spatial analysis have predicted a response? One would hope so, rather than the bulk RNA-seq, which is like you take all the tissue and you throw it in a blender and you get the components, like you were going to get a smoothie and you said there's so many blueberries and such. But now with your spatial, which I'm loving, we can get the nuances. And of course, we're hoping to go beyond just PD-L1, since we especially as prostate cancer patients are mostly cold tumors, but this type of glimpse inside of what's happening in the tumor microenvironment is fantastic, and I hope someday will lead to directed therapies. Probably didn't matter in Phil's case, but I would suspect we would have seen an infiltration of T cells, because if Pluvicto is going to work on PD-L1, you got to have some T cells. You got to have the right players in the microenvironment. So I think is great work. Next up, so a prediction of response is something that this would be able to provide far in excess of the standard H&E stains. But when we think about the 40-plex, I mean, you're going 40-dimensional. You have a lot more information, so you can nuance beyond PD-L1. So you could look at B7H3, like the clinical trial I'm on, or how to reverse the desert. So those are my comments. I mean, reversing the desert to enable your immune system to work is something that I've been looking into, or we're all interested in it, of course. So you now have a 40-plex, and you can guide those 40 markers to help take us to the next step in the revolution against cancer. Is what I think. The only trouble is we need tissue. So we have this tissue, we see where it was, we make a prediction, but now we intervene in some way. What happened? That requires more tissue to find out what happened. So I think BostonGene is. I talked with Brian about this, and I'll quit talking. Talked with Brian about this, about are you offering RNA-seq on circulating tumor cells? Is that something inside your portfolio that would maybe be of interest? And Michael, you can answer as well.
So not yet. So right now we are developing these technologies in our lab.
Okay.
Yeah,
so yes.
I think that came from a conversation with Brian and Chadish, who's leading this effort in our lab, this technology. And so it is in development. Obviously, RNA within this level is extremely fragile. So a lot of it has to do with blood collection and everything that happens till it gets to our lab. And so that's one of the most difficult aspects. And going back to MxIF, obviously the question is clinical utility, right? So in a lot of the projects that we're doing with MD Anderson, the broad projects are doing the tumor portrait testing, and then gauging response to whether it's immunotherapy or whatnot. But then what we've done is in some of these high responders or some of these non-responders, we're going back to use MxIF to better understand that. I think one thing that Kate shared, and one thing that's very exciting to us, is us to be able to identify these different cells that have penetrated the tumor versus that are outside the tumor. And the question is, why is that happening or not happening? But I think that standalone, it's not there, but to offer greater insight, it's definitely there. And so that's where MxIF is being used from a research side. Kate may have some to add because I'm focused only on MD Anderson. But I think that, when we talk about this, the tissue assay, the blood assays, the MxIF, it's just, we're trying to go so deep to decode the cancer in unique cases to really understand what's driving response or lack thereof. And I don't know, Kate, if you want to add anything to some other projects that you're working on.
No, this is a great comment. Yeah, this is a great comment. So right now we're working in both directions. So the first, I'll just describe the biomarker. When we provide tumor imaging report, in addition to our tumor portrait report, for example, in cases when we see the highly inflamed case, to just confirm where those immune cells are located. And another way, we also do a lot of research work as well. So we compare multiplex immunofluorescence data with the bulk sequencing data. So for example, if we see there are a lot of immune cells came to the tumor, but we see almost all of these immune cells are on the tumor stromal border. And next, we using bulk RNA sequencing to see the cytokines and chemokines, to see what happened in the tumor, why the immune cells are stuck on the tumor stromal border and do not penetrate the tumor itself. So this one is more likely research work right now, but we are working in this direction as well, trying to identify the biology of the tumor itself and why some tumor have the not exhausted, but the phenotype cold, even if we see a lot of immune cells in the non-malignant component around the tumor.
Okay,
next up, I was going to go with David. David Plunkett had his hand up.
I'm not sure if this is a good follow-on or not, but my question is, what's your experience with the durability or fragility of the tissue samples? Is there an age after which it's not really practical to do an analysis? Then you need a fresh tissue sample. For example, my biopsy was 4.5 years ago, and I don't know if it would actually be useful to try and do any analysis on those samples at this time, even if I had access to them.
So we know 4 years is not that old biopsy age. So for our tumor portrait report, we can utilize this sample, and for multiplex immunofluorescence, it is also can be utilized. So we for our assay, we need FFP tissue sample. So if you mentioned that you have like fresh frozen tissue sample or FFP. So it doesn't matter. So if it is fresh frozen, we can embed this in paraffin and proceed with the staining and with the following analysis. If it is already embedded tissue, we can cut one slide and perform multiplex immunofluorescence to see the morphology of the tissue. And
the vast majority of tissue samples, over 98% that we receive, are preserved in formalin blocks. So that's the vast majority.
Right. So one thing maybe, so in if the block, FFP block, is younger than 5 years, we can work with this block, but it will be better to have block instead of just slides. For example, if it is 5 years slides, so it looks like MxIF will not work well from this type of the material because we need to fresh cut epitopes.
Okay, so letting a patient know in advance what the limitations or requirements are, I think, is important, because if I can avoid going through another biopsy, I'd certainly prefer that.
Right, it's true on one hand, and on other hand, the tumor can be changed within this 4 years significantly. So if you would like to have the actual information about the current
Good point.
tumor, yes, it will be better to have the fresh sample.
Thank you, David. Kamuri?
Thank you, Brad. Thank you, Katerina. This is amazing information to have here. My question, I'm going to try to do two for one. Okay, I'm going to put in two questions. One is, do you see significant differences between the primary tumor and metastases in patients where you're able to obtain that sample? I know sample is limiting. And my second question is, are there any cancers that are just so notoriously difficult to do this kind of work on that you just avoid upfront?
So I can speak about the primary and metastatic first from the bulk RNA sequencing point of view. So we do not have any batch effects between those two type of samples. So for example, when we receive some solid malignancies from metastatic side, we still be able to compare this sample with our internal cohorts because we do not see any batch effect with the primary sites. For multiplex immunofluorescence, we just do not have that much cohort samples. So we have some multi-regional samples, and those samples can be different from each other, mostly because of the presence of tumor or immune cells itself. So it's not like that much difference, like this is a primary site, this is metastatic. So it's like mostly because of the tumor sample itself. For example, one sample has the more tumor cells inside and other samples have less tumor cells inside. And the second question was about
any cancers that are notoriously so difficult, to,
Right. So speaking about multiplex immunofluorescence, we don't have any issues with different cancer types. We have only one issue with the preservation method. So for example, if it will be metastatic site with presence of bone sample, so we will need to do the decalcification. And to be able to perform bulk RNA sequencing or whole exome sequencing or multiplex immunofluorescence sequencing or multiplex immunofluorescence staining, this bone marrow sample should be decalcified with EDTA solution. So usually in pathology lab for the decalcification, they utilize acids. But for NGS and for multiplex immunofluorescence, this solution will not work. So we require the different type of the solution for bones decalcification within the sample.
Yeah, can I add a small, when there's necrosis, highly necrotic tissue in the tumor, is that, do you flag that up front, or is that, how does that work?
Yes, so we, I will speak in both. So for example, if we're speaking about NGS and we see necrotic tissue, we analyze the presence of the necrotic tissue in the sample. So for example, if it is not broad necrosis, we can just so we can just perform the macro dissection and remove the necrotic tissue and still be able to proceed with the NGS data analysis, NGS data generation and analysis. If we are speaking about multiplex immunofluorescence, necrotic tissue doesn't affect us at all. So from the research perspective, it is also really interesting to analyze this type of morphological structure within the tissue, because sometimes it is full of macrophages and etc. So for NGS, we're trying to remove this, as well as blood on this, blood on the slides. And from the multiplex immunofluorescence point of view, we don't see any issues here and can proceed with the staining. And we will just decide, do we want to mask this area and analyze this as a separate morphological structures, or we can perform the cell segmentation, and then we will see the difference on the cell typing step.
Thank you.
And just to piggyback on your question about primary versus metastatic lesions, in various departments at MD Anderson, in some cancer types, it's uber important to test the most recent metastatic lesion to see how the behavior of the cancer has changed, because we know that a lot of therapies like endocrine therapies and breast cancer can change the histology. But there's some cancers, and like with a project we're doing with Dr. Subudi, where we're going back to the 2011 prostatectomy for the tumor microenvironment. And so I think that a great area of interest. I don't think there's an answer to this now, and we've discussed this in our prior calls, is how do you make an immune microenvironment hot, cold turn hot, and what makes it hot turn cold. And so, in many of our cases, we are being able to do longitudinal testing. And so we have treatment in the middle. And what we do at BostonGene is we will do each individual test, and deliver the tumor portrait report. And then what our team does is we add what we call a tumor evolution report. And so we show differences in key biomarkers. So we'll show differences in, TMB and PD-L1 and so forth. But we're CAP-CLIA certified to show individual RNA expression. And so we can show changes in RNA expression levels between the two different tissue samples. And this is mostly hypothesis generating because we don't know yet, but it's interesting how some therapies can really affect these key biomarkers.
Thank you.
Thank you, Michael. Brian, you're up next.
Hi, Kate. It's great to meet you. As Michael mentioned and Brad mentioned, I'm just in the process of going through your pipeline. As a matter of fact, I was just sending an authorization to UCSD to release my tissue from 2016, which is my prostatectomy, as well as my most recent surgery, which was in November 2022. So there's a few things that you mentioned that I want to kind of drill down in. First is, you said that beyond 5 years, I believe, the tissue starts to degrade, and you'd rather have a piece of block tissue. So my prostatectomy was 7 years ago. Should we include that? And Michael, I mean, this is kind of getting into some of the details too, right? I mean, so, we're going to do the immune profiling. I don't know if we can do the spatial profiling. I think, Michael, you're still maybe working on that. But if so, that's one question. The second question is, if a patient has access to do both spatial and your standard immune profiling work, you have limited tissue. Can you run both tests on the same tissue, or do you have to prioritize one or the other? I mean, tissue is a precious thing.
Yes, so can I start answering the second question? So for example, yes, I think we should prioritize one test, and for our tumor portrait test right now, we request 10 unstained slides, but we have developed the algorithm which can predict the number of slides which we will need to take into the extraction. So we can request 10 unstained slides, but when we will see the tissue and we will see that the cellularity of the tumor is great and the area of is enough, so we can utilize the less slides than we requested for like tumor portrait analysis, and then we can make a decision to run the additional test, like one slide for multiplex immunofluorescence assay. So it definitely should be prioritized because we cannot run two tests in parallel. So we can run tumor portrait test, which is bulk RNA sequencing, and whole exome. This can be run in parallel from the one set of slides, from the one step of the extraction. But multiplex immunofluorescence should be go further. And if we'll have enough materials or one slide to perform this test. And speaking about the biopsy, we have an experience working with a 7 years biopsy for tumor portrait test. So we still see, so we can process this for bulk RNA sequencing and whole exome sequencing. So we just need to decide, is it crucial to know the information about the 7 years old biopsy?
Yeah, and I think that, because I see a lot of older tissue that's requested for tumor portrait testing. Obviously, the older the tissue, the more, the higher the chance of mainly RNA extraction. RNA can degrade. But if there's really strong tumor content that, like Kate was explaining, that we can go and analyze and macro dissect, then it enhances our chances. Obviously, if it's very small tumor content, the failure rate goes very high. But in many of the cases that some of our projects that we're requesting old tissue from the primary site, what I've seen is that we're usually pretty good and successful with DNA extraction. It's RNA that really becomes difficult. And a lot of the BostonGene magic with the tumor microenvironment profiling and all that stuff comes from RNA sequencing, but we can deliver a DNA only report, which basically shows everything we found in whole exome sequencing. So, part of your case, Brian, is to get that primary lesion, and fingers crossed we're successful, and then do your most recent November 2022 surgery. And then what we're going to do is, I'm confident with that because you said that was pretty significant tumor content there. So then fingers crossed we are able to deliver both, and then we can deliver the tumor evolution report and really understand kind of your transition. It'd be nice to add it to your amazing portrait of your whole timeline. So it'll be really exciting.
Yes, and you also mentioned that immunoprofiling. So we do immunoprofiling from the blood samples. So this is our comprehensive flow cytometry approach, and the team have developed the immune fitness score. So we know that the blood, the presence of different subtypes of immune cells within the blood from the healthy donors and from the cancer patients are differ. So the team can predict the therapy response to immuno-oncology using the blood samples as well. So immunoprofiling or blood test is really, really powerful tool in the immuno-oncology standpoint of view too.
So just, I don't want to dominate the conversation here, but this is sort of like a real life case, and hopefully this will be useful for everyone, because I think to a certain extent, we are defining maybe a little bit of a new path in terms of what to do with longitudinal information about mean tissue specifically. So Rick just brought up a good point, which is to say, I had a midpoint resection in 2020. So I got 3 tissue samples: my prostate in 2016, a resection, a MET resection in 2020, and then another MET resection in 2022. So does it make sense to take all of it? Would we be better off taking the 2020 resection? How do we, again, there's only so much tissue that a patient has. It's precious currency. So understanding how to maximize the utility of that tissue is critical before a patient actually goes through with this process. So help me understand, what is the best way for me to prioritize my tissue for diagnostics?
So if you will take all 3 time points and you receive the treatment, you can definitely see did the tumor change the tumor microenvironment subtype. So for example, was it cold or was it hot? Was it had more mesenchymal subtype, and how the tumor changed when you took the drugs. So we definitely see more story using the 3 time points, but
I mean, ultimately, so Kate, I mean, ultimately, I love data as much as, anybody on this call, right? But really, it's about how to translate that data into treatments. So, I've got a meeting that Michael set up with Mike Goldberg coming up on Friday. Well, I'm going to be bringing, hopefully you can make it, Saul Priceman. So Saul basically he's the brains behind his lab, drives CAR T development for the City of Hope. And so, one thought is, how do we use all this great insight to develop some type of immunotherapy, whether it's CAR T or something else, that can attack my cancer. So in the context of this menu of tissue and corresponding data that you're going to have, 3 resections, 3 tissue samples, what is the best way for us to leverage that tissue and insight into treatment decisions for me?
So for the real treatment decision, the relevant will be the latest tissue sample. If you would like to see how your tumor react for the previous treatment options, it will be better to analyze all of 3 to see the full history. Like, for example, you received one drug, and next you check how the tumor was responded to this drug. You received another drug, how tissue was responded to another drug. But for real prospective treatment decision, the most important one, the recent tumor sample.
Yeah,
Okay.
I would agree with Kate. So, and we discussed, this is kind of a special project. So the greatest clinical utility is the most recent surgery. The going back to do the original surgery, that is more thought-provoking where you started. Obviously, if in discussions with Dr. McKay or Mike Goldberg or, and they think that we should go to the midpoint because you're so far gone from that original, the original diagnosis, then we could do that. But we have, we've had quite a few private pay patients that have done, 5 or 6 BostonGene tumor portraits, not only just evolutionary, looking at different time points, but if they have multiple anatomic lesions taken at the same time at different metastatic sites, then we've done multiple analysis. I think outside of Brian's unique kind of case where we're doing this partnership, the elephant in the room is insurance reimbursement, right? Because that's very tough. And so from commercial patients, we're often limited on, how many tests we can run. Obviously, we believe that there's a huge, profound opportunity for serial testing before and after treatments. But the really gatekeeper is insurance companies and reimbursement. As regards to the immunoprofiling, so in our research setting, this is being used serially, like while patients are on immunotherapy treatment. So we have a metastatic trial where the immunotherapy is being used, being treated, I think, once every month. And so before each treatment, the patient does a blood test. And so they're adding an immunoprofiling to that to their normal blood test. In Brian's case, I don't think that we've identified the clinical utility for our immunoprofiling test because it's based on pre-treatment and then during treatment, post-treatment. And that was kind of the topic for him meeting with our chief immunologist, Mike Goldberg, because Mike Goldberg has developed this test and he is the expert on this test. It will be very interesting to see where that conversation goes and where the, you want to have clinical utility behind a test, even though it's exciting to get insight and it be thought-provoking. So it'll be interesting to see how that conversation goes. But Brian, if in your discussions and you take feedback to your oncologist, if you want, we've promised 2 tests and then to do the tumor evolution. If you decide you want to go to that midpoint, we can change it. It's no problem at all. So just let me know.
Okay, cool. All right, I'll let others jump in here. Thank you, guys. Excited about the next steps.
Yeah, Gita's up next.
Let me get my camera on. I'm so sorry. So I just want to, for full disclosure, say we do bulk RNA sequencing translated to treatment options using a platform. With that said, we are super interested in potentially collaborating in some form. We do not do anything on the spatial side, and we have a project with the NCI where we are interested in validating some of our findings using IHC. So my question is really because doing one marker on one slide, and we talked about the availability of tissue is always the issue. My question is really if the PD-L1 and some of the other biomarkers that you have, and I know not all of them is FDA approved, but PD-L1 is, if you have done any validation up against the existing IHC methods for PD-L1, androgen receptor, ER/PR, HER2 in particular.
Yeah, thank you so much. This is exactly what we're doing. So this is a like separate flow for us, provide the clinical utility of bulk RNA sequencing data, and we do the correspondence analysis between IHC and bulk RNA sequencing. So we stain the same samples with IHC and do bulk RNA sequencing and provide the cutoffs, what is low, medium, and high on bulk RNA sequencing through the analyzing the IHC data. So we have already performed this analysis for PD-L1, ER, PR, HER2, TROP, folate receptor. So right now, the work you are asking already done. So we have.
No, I was more asking, for instance, for PD-L1. I understand that you're also validating your bulk RNA-seq, but my question was more for PD-L1. Have you also sent your slides out for third-party staining? So your internal staining have been validated.
So during the LDT validation process, we send samples outside. So we stain sample in-house and also send to external CRO vendors to stain to provide like a proof of validation. So right now in our everyday practice, we launched our own PD-L1 22C3 clone. So we don't need to send the samples externally. So we can stain all of them in-house. But during the LDT validation, for our multiplex immunofluorescence markers as well. So we stain MxIF markers, we stain multiple slides with the individual IHC markers in-house, and we send those slides, unstained slides, to the external CRO to stain IHC externally. So like huge process of
so if it's validated, maybe there's a way we can collaborate, because obviously there's a plurality of biomarkers that we would like to validate in this particular project. And back to what we all know, there's a limited amount of tissue in those FFP samples. So if you have validated the biomarkers, we can potentially send you a slide, and we can see what we find there and consider that as a LDT validated PD-L1 or androgen receptor and ER/PR, HER2. We don't know yet exactly what the list is going to end up with, but those are the most common IHC. And our focus is really also cold tumors and tumors with low mutation frequency, which doesn't at this point benefit that frequently from immunotherapy. Yeah.
We will be happy. Yes, we'll be happy to collaborate.
Yeah, you're
Fantastic.
both in Boston. You're both in the Boston.
We are, and we can meet at any time, and also on Zoom to figure this out. As long as we can claim that the markers that you have is validated. We do know that most of the findings will not have any IHC biomarker that is validated. So that's the other problem, that it's not FDA approved or used in the clinic. So there's this vast unmet unvalidated space out there. So I like what you're doing with the multiplex a lot. Thank you.
Thank you. So Katerina, we're just about at the hour. Do you have time to run over, or you have a?
Yes, time. Yes, I have time, and I also have a lot of questions in the chat. Maybe we
I
can.
saw from, yeah, Rick's been going crazy. He does that. But Alan Morris, and then Rick, and then we'll try to wrap up. Maybe just run over 5 or 10 minutes here. Alan.
Hi, Katerina. I listened to your lecture and I saw that you do spatial analysis. Is that right? You're doing spatial analysis, and it looks to me, correct me if I'm wrong, that you're trying to separate with all your data tissue tumor tissue into inflamed states and then 2 separate cold states, one immune excluded and immune desert. Is that correct? That's what you're trying to do. Have your group ever looked at segregating the Gleason scores patterns? Like, for example, do you have an idea of what % of Gleason score 3 is inflamed? Do you know what percent?
Yes, no, I do not know, because we didn't have that much samples to be able to to receive the, I don't know, equal group of samples with each Gleason score. But
can I tell you something?
Mm-hmm.
I've been looking at prostate cancer for 40 years, and I'm going to give you my hypothesis. I don't do it. I certainly have not done it in any kind of sophisticated fashion where I'm looking at CD8, CD4, tumor-associated macrophages, stromal cells. I look at it the way we've looked at it from 1850 on by light microscopic H&E stain. And I can tell you, I've been looking at Gleason pattern 3 for 40 years, and it's never inflamed. So my hypothesis is, if you've ever looked at it, you will see that there are, I shouldn't say there aren't tumor infiltrating lymphocytes, because here's another problem I saw with your 3 things, and that is prostate cancer naturally has prostatitis. So I would hope that your algorithm subtracts out background non-neoplastic prostatitis. Because, for example, you have immune desert as having absolutely no inflammatory cells. And I can tell you that is not the reality of prostate. Or as far as my hypothesis goes. My view of immune desert is that the cancer cell has not evoked a natural adaptive immune response to the tumor, okay? And your immune desert picture was defined as something that had no inflammation anywhere, and I can tell you that's not the reality. The reality is you have background prostatitis, and you frequently do have, my gestalt is the immune desert state. I'm giving you my hypothesis. The immune desert state in prostate cancer is actually incredibly high. And it's backed up by the Provenge data, which shows that the patient is immune naive before they even get Provenge. I guess that was really compound, but I think it behooves you to get a pathologist to look at the patterns 3, 4, and 5, and I'm going to give you my hypothesis. 3 is an immune desert. 4, incredibly infrequently will you have an immune reaction to it. It's only the 5s, the really poorly differentiated ones that have high tumor mutational burden, that are going to evoke an inflammatory response, especially those that are undergoing cheminonecrosis. You're probably not a pathologist, so you don't know that the cheminonecrosis pattern is a Gleason 5 pattern that is particularly inflamed. I'm sorry, I'm sure I overwhelmed you, but you guys probably don't have a pathologist that's really honing down on this stuff, I suspect.
We have. So we have big of medical doctor pathologists who help us analyze the samples and help us to prepare the quality control of the tumor samples prior to sequencing. But yes, I understood. And yes, we see a lot of immune infiltration in non-malignant component because it came from the inflammation around the tumor. Yes, we see this as well. Thank you so much.
So I'm sorry, your algorithm, your AI algorithm, which obviously is very complicated, subtracts out the background prostatitis. Is that correct?
Yes, so yes, we can split malignant cells from the non-malignant cells, and we can identify prostatitis. Yeah, the
Right.
inflammation.
Then your pictogram of immune desert should be modified to include prostatitis in the background as a potentially immune desert state. Is that right?
So yes, we just do not have so much samples. So yes, this can be, so from the data analysis standpoint, absolutely yes. So we can identify the immune cells in the different morphological areas on the tissue. We can split, like, is it real cold tumor, or is it inflamed tumor? Is it cold tumor with the presence of immune cells with the inflammation, with the area of inflammation? So we can split all of these morphological different conditions based on the data.
I'm going to ask you what I view as an incredibly important question. And I know you should look, this is what you guys should do. You should look at Gleason 3, and you should look for the stromal component. And if the stromal component is altered, do you know, I'm going to ask you the question, and I know you don't know the answer. Have you looked at Gleason 3 pattern and seen whether or not there's a stromal change?
So yes, we do not have that much samples to make a conclusion.
Okay, well, I'm going to tell you.
Alan,
Gleason,
Alan,
yeah. This is incredibly important.
You made your point. You made
Yeah.
your point. I want to give Rick a chance because we have just a few more minutes. Is that okay?
Yeah, I'm just letting you know, if you go down that route, since you're a theoretical company, you will make a huge breakthrough in prostate cancer.
Thanks, Alan.
And apparently none of the, I've been asking around, and none of the academics are onto this. A Gleason 3 has no stromal reaction, and that's why there's no hard digital rectal exam by virtue of palpating it.
Thank you, Alan. Rick, you have a few questions. Try and be rapid fire here in the last minutes.
Yeah, I've got some technical questions, whatever, like how do you normalize your RNA-seq, all this, all these little bioinformatics questions. How do you pick your 40-plex membership?
Mm-hmm.
But the real question here for the last is, what are we going to do with Brian? And I've seen Akoya's presentations, NanoString's presentations. I've tried to get them, but it always falls short. So especially the spatial, which it looks like spatial is falling short here as well. So we're talking about all this advanced stuff that really we can't access unless this is the nature of this question. What can we access, and how do we break through, with Michael, with your amazing analysis? If we can't access it, it's just research stuff that is pie in the sky, and it's almost a waste of time for us. So we need to access your amazing technology. Your RNA-seq, I have no idea what you do. It's, probably based on immune deconvolution and R. There's no magic sauce there to me, but okay, if you're going to do that, that's great. You probably have a pipeline. Awesome. But that's really the nature of my question. What can we do with Brian? Open this up so that BostonGene and Cancer Patient Lab start working together, and we can run it up the flagpole. Hey, look, BostonGene did this for us, rather than we talked about it. Oh yeah, it's unaffordable. Yeah, we can't do that. I guess I'm so frustrated with, NanoString, Akoya, and, the other interpretations on Codex. Can we actually move something forward here? Like maybe a low cost pilot, one-off?
I'll take that, Rick. I mean, so obviously, as we spoke about last time with Michelle, the elephant in the room with MxIF is the labor, and the technology is very expensive. We do offer it in a private pay situation. I think that the best way, and this is where I was going to go, is if we could find some type of efforts to to fund a cancer patient lab project with you guys, where, you know, and what we do with many of our cases is offer a discounted rate to be able to collaborate together. But I think that the most important part is, you know, with Brian's case, is it's really going to be the most recent tissue, doing the BostonGene tumor portrait test on that, and understanding the behavior, the personality of his cancer at this moment in time. And that is going to be the clinical utility. Everything else that we do as far as MxIF and stuff is just offering insight and maybe giving higher confidence to future treatment selection. But the clinical utility for some of these tests is not there yet. Now, that's the promise, is to develop the clinical utility. And how does it change treatment decisions? We're not there yet. Right now, we are there with the BostonGene tumor portrait. And so all of these other exciting, you know, technologies just help us to decode the cancer, so to speak, to continue to understand the biology before and after treatment. And unfortunately, you know, that's just where we're at, you know, but I believe that we are moving the needle as fast as possible. And, you know, from Brian's case, the tumor portrait's going to be the most important. Everything else is just kind of value adds to bring this story to life, and knowing what Brian's been on before and kind of giving a greater insight to why he responded or progressed on previous therapies.
So the tumor portrait is based on RNA-seq?
It's whole exome and whole transcriptome, so it's DNA and RNA. So most of your action comes from obviously the DNA component, because that's where you're finding all your biomarkers that are mostly actionable. On the RNA side, we're looking at fusions, individual gene expression, as well as we use our, as you know, our deconvolution tool to create the tumor microenvironment and in the microenvironment composition and so forth. So the RNA is kind of a lot of thought-provoking insight. DNA is still where most of your clinical action comes from.
So you don't have any secret sauce, really. You don't have anything. You have a pipeline.
We have I think we have a lot of secret sauce.
I don't hear any. I don't hear any.
That's in our depth of coverage, our ability to call not only fusions but expressions. And tumor microenvironment profiling is unique to BostonGene. We're seeing a lot of clinically actionable therapy choices based on that. And so I think there's a lot of talent just in the sequencing. So, you know, sequencing is not a commodity. We definitely know that. So
I don't see anything novel. But I invite, you know, let's push it forward and prove me wrong. Doesn't look like you have a pipeline. That's nice.